Welcome to the Department of Health's COVID-19 press update. My name is Jody McGinnis Porter, and I'm the Communications Director for the Department of Health. Today's hour-long event will include a presentation from Acting Department of Health Secretary Dr. David Scrace and State Epidemiologist Dr. Christine Ross. They will give us an update on where we are in the pandemic, useful tools to coexist with COVID, and more. After the presentation, we will address questions from the media. We have a hard stop at 2 p.m. and I thank you for understanding in advance. We have several reporters that submitted questions in advance, and we'll go ahead and respond to those in writing. And we do ask that our media partners limit their questions to one this afternoon, and we'll try to get as many of them answered live in the press conference. If not, please send an email to me or Katie Dippendorfer. You should have our email addresses in the media advisory, and we'll respond to those in a written response. And without further ado, I'll turn it over to Dr. Ross, our state epidemiologist.
Hey, wonderful. Thank you, Jody. Let me just do an audio check. Can you hear me okay?
Yep.
Okay, fantastic. So hello, everyone. Thank you for attending this COVID-19 update. It's been a very long road for all of us. And although COVID-19 remains a serious disease, I'm happy to say there is some good news that we have the opportunity to share today. So I think I'll go ahead and move to the first slide. So I think this is one that's familiar to everyone. So on this first slide, you'll see the Ebby curve for the state of New Mexico. This is on the left-hand side. And this is where we plot the reported cases or infections over time. So the far right-hand part of this slide is where we are now. So you can follow that black dotted line along, and you can see that we've been seeing a rising number of cases for several weeks now. Our cases are based on reported cases to the state. So we know that this is less complete than in the past, and this is primarily due to changing testing practices, namely the increase in home-based testing. But as epidemiologists, we always stress that the absolute number is often not as important as following a trend or watching that black line over time. This provides a tremendous amount of situational awareness, which you can see that it is showing us clearly indicative of another wave of infections. So on the far right-hand side, I just want to point out, this is simply a blow up or where we allow you to see the recent 6-week view in those newly reported cases over time. You can see there was a little bit of notch in that black dotted line where we saw a little bit of drop, and then we began to increase again. So next slide. So hospitalizations have also increased, and you can see this on the left-hand part of the slide. This is COVID-19 positive patients that are in the hospital. I believe this is absolute numbers. And so again, you follow that number, you follow that black line over time, and you can see that that has clearly increased. What is important to note here is although there is an increase, it is not anywhere near what we saw last winter, driven by the Delta surge, and then followed by when Omicron was first introduced into the state, again, back in the winter months, which you can see there on that slide. On the right-hand part of this slide, you see COVID-19 positive ventilated patients. Why have we shared this with you today? Well, we want to explain that even though we see these hospitalization numbers going up, they are not anywhere near what we have seen in the past. Well, similarly, we are not seeing the same trend in ICU level numbers or patients that require mechanical ventilation. I think in the past, we have seen a range from 12 to 20% of hospitalizations requiring ventilation or mechanical ventilation. And now this number is around 3.5%. So again, very different. So these are very important and welcomed differences from prior waves of infections that we've seen. So let me go ahead and go to the next slide. So this slide is depicting the CDC COVID-19 community levels. This is a framework that uses case rates, but then it really focuses in on what we call medically significant disease, because what they're monitoring, and not only case rates, they're looking at new hospital admissions and COVID-19 occupancy rates. And they use these three metrics to determine a low, medium, and high level. And as you can see, similarly across eastern part of the United States, and then slowly we're seeing pockets of increased activity across the US, including in New Mexico. So on the right-hand part of this slide, you'll see a blow up of New Mexico, and the table is indicating where our counties sit in that low, medium, high framework. You can see right now we have 0 counties sitting at that high level. We have 24, or what represents 72.7% of our counties in that low level, and 27 or 9 counties in the medium level. What's important to note there, though, which is not spelled out on the slide, a large proportion of our population is actually residing in counties that are sitting at that medium level. So this is important to understand, and I think Dr. Scrace is going to go into a little bit more later. So I wanted to mention that clearly what we're seeing with this wave is very different than what we've seen in the past. We cannot say with certainty why this is, but we think it's due to multiple factors, or potentially these different multiple factors. Properties of the circulating Omicron subvariant. So currently our dominant strain is the Omicron subvariant BA2.12.1. So are there properties of this subvariant? We know it's very, very highly transmissible, but is there inherent properties there which are leading to less severe disease? Other factors that are most likely playing a part is that we have high levels of immune protection. In other words, I kind of think of it as a wall of protection created by vaccination, but also from natural infections, even reinfections. So most of us are either protected by vaccination or prior natural infections. So this creates this wall of protection for us. And also now we clearly have access to effective treatments. So that's also much, much different than early in the pandemic. So what this effectively means, there are clearly a lot of COVID-19 infections in our communities right now, but despite this rise in cases and community transmission levels, hospitalizations, ICU admissions, and deaths remain comparatively low. It just can't go without saying that any COVID-19 related death is obviously one too many, and we really hope very soon to see the day when we are reporting out 0 COVID-19 related deaths. But in summary, right now, we are clearly in a very different pandemic, if you will, than we have seen previously. So what do we recommend? Again, I think Dr. Scrace is going to spend more time on this, but I just want to take the opportunity to mention that people, especially those at high risk for severe illness from COVID-19, should be aware of the current situation. I think most of us currently know someone who's infected with COVID-19. So I think most people are aware that there are a large amount of infections happening in the community. And you need to understand the recommended prevention steps that you can take. I just can't stop without mentioning that the COVID-19 vaccines remain the best option to lower your risk of severe illness, hospitalization, and death if you happen to get infected. But it's important to understand that these vaccines become less effective over time and they need to be boosted. People who are up to date with a booster have a much lower risk of severe illness and even death compared to unvaccinated individuals. There is some data that I had recently looked at on the CDC COVID-19 tracker, and I'm happy to provide that link later on. This is from March 2022, and what they show there is that unvaccinated individuals aged 12 and over were nearly 5 times more likely to be hospitalized and 17 times more likely to die of COVID-19 than people who were vaccinated and up to date with a booster. So really, really, really powerful tool. Treatment can also reduce the severity of illness, but it requires testing, and it requires that you seek out treatment quickly. Lastly, we know that masks and social distancing work, and while these are clearly voluntary, really should be considered to reduce your risk in public settings, especially if you are one of those individuals in a high-risk group. And then just, I want to quickly mention, because we haven't had opportunity to provide an update recently, I want to give you a quick snapshot of what we are doing. So we continue to closely monitor the trends in cases, hospitalizations, and deaths from COVID-19. We continue to monitor the genetics of the virus per the excellent work of our state laboratory. We are working to set up surveillance for the virus in wastewater, and we are making some strides there. And we continue to monitor and ensure availability of testing, vaccines, and treatments. And then this one goes without saying, we have a very, very, very busy group, and we are always participating in national dialogues to ensure that New Mexico is operating with the best information and best practices available. Okay, so that's a quick snapshot of where we are. A lot of things that I referred to are available in our Ebby reports that are posted online, and then also on the CDC COVID-19 data tracker. So right now, I think I'll turn it to our Secretary of Health, Dr. Scrace.
Thank you, Christine. Brianna, why don't you just advance the slide one? And, or whoever's running the slides, let's advance the slide, one slide. I'm gonna take the message about the toolkit a little further. Before I did that, though, I wanted to really acknowledge Christine, Dr. Ross. She's just an incredible leader. She's been a great thought partner to me. There's probably, excuse me, nothing I think about the pandemic that hasn't been informed by my discussions with her. And, you know, she and I are supported by an amazing group of people in our state epidemiology team who work really hard and have spent many, many, many weekends here since the beginning of the pandemic. And they've done an amazing job as well. You know, our state has been a national leader because of Christine's work and our ability to manage so much data and send so much information to the CDC. You know, but Christine does a lot more than COVID. She was telling me a couple of weeks ago, a woman was attacked by a rabid fox, and Christine ended up getting involved, which is what epidemiologists do, providing consultation with the emergency department. She got the appropriate antidote, rabies vaccine treatment. She drove it herself on her day off down to Socorro, New Mexico. And that's just one example of many things she does when we're all sleeping, and her team does while we're all sleeping, to keep New Mexicans safe and to deal with the many, many public health issues we deal with here in the state, not just COVID. Christine's going to be leaving the department on July 10th. She's going to spend the summer with her family. And I hope that we continue, you know, I know I will continue contacting her and calling her up with questions if she'll still take my calls, but we're just so privileged to have her here and sad to see her go, but I just wanted to acknowledge the amazing contribution that she's made. So things aren't exactly back to normal. I think we all know that, but we're actually in a much better situation than we've ever been before. We have way more tools to fight the coronavirus and all the new variants. And so I want to talk about one today and really drive it home and ask you all for your help getting the word out on this. It's about treatment. And now, if you have a positive test, and I do want to say that if you have a positive home test, you have COVID. You don't need to get a PCR test. And then you have one symptom, any of the symptoms of COVID, and you can look them up, but cough, fever, headache, loss of sense of smell and taste, fatigue, any of those symptoms, and then just one risk factor. And that's a long list, like being over 64, having high blood pressure, lung disease, heart disease, immunosuppression, of course, diabetes, obesity. So one test, one symptom, one risk factor, you should get treatment. And we've seen a real surge that I'm very happy about just in my own patients. I think I've written, 5 Paxlovid prescriptions in the past 6 or 7 days. And I don't have that big of a practice because I have these 2 jobs at state government. It's best with Paxlovid. It's the National Institutes of Health. That's the tier 1, the preferred medication, reduces your risk of hospitalization by 88%. Everyone should try to go for that first. It does have interactions with other drugs, so you need to work with a healthcare provider to make sure the drug is right for you. Second tier is Remdezzevere, which you might remember from the beginning of the pandemic. We've been using it as an inpatient drug to treat COVID. It also turns out that if you get 3 doses IV on 3 consecutive days, that dramatically reduces your risk of Paxlovid. Your risk of COVID and hospitalization, a COVID-related hospitalization and death. And then tier 3 are other drugs that aren't as effective. And interestingly, we still have a lot of people going to the ED saying, I don't want Paxlovid, I want monoclonal antibodies. The only one we have right now is bebtelovimab. If you can't take Paxlovid, that's one of your choices. But if it was me, I definitely want to be on Paxlovid. It's much more effective than the monoclonal antibodies we have now. And so next slide, please. The good news, we're tracking all the therapies for COVID that can be given as an outpatient treatment and that are effective. You'll see some of the early colors like red and purple have gone because they're no longer effective against COVID variants. But I'm very pleased to see that I hope we break 1,000 Paxlovid doses this week. That's the yellow bar on the extreme right of the graph. Last week it was 939, and you can see the other treatments, the bebtelovimab and molnupiravir, the other drug as well. Next slide. We just thought you'd be interested in this. This is another one of my favorite slides. There's really good news here and there's bad news. The good news is that probably all comers, maybe up to half of New Mexicans, are eligible for these treatments. And we've made incredible progress on the percent of people we've treated over particularly the past 4 weeks. We've been above 30%. So that's really good news. I'd like to see us at 40. The problem is that the numerator of this is Paxlovid prescriptions and the denominator is PCR tests. And so we now know that for every 1 person getting a PCR test, there are, and we don't know the exact number, let's just say 3 to 7 additional people being diagnosed with COVID based on a home test. So this is for all you folks out there doing home tests, and we're trying to get labels to put on the home test to remind us to call your provider for treatment if your test is positive. Next slide. So, we have an incredible arsenal of tools. When I think back to the first year of the pandemic and how little we had to fight COVID, it just amazes me how much we have now. First, all our data on the website, we update case counts, hospitalizations, intubations, tests, deaths every day, Monday through Friday. We have new vaccines, and I think we're all excited about the deliberations this week and next about the new vaccine for kids age 6 months to 4 years, a 3-dose variety. Masks are just as effective as they were in the past. These new strains of COVID are much, much more infectious, but they still will lower your risk of getting COVID if you wear a tight-fitting mask that's a respirator, which is a N95 or KN95. If you wear that consistently, testing, hopefully all of you have tests in your own home. Treatments, I just talked about, really critical. I think that is the game changer for the pandemic is oral treatment. With the first wave of Omicron in January, February, we had 700 people in the hospital. You saw that we're running 130 to 140 just most lately. And I attribute some of that to hopefully the virus being less serious and putting less people in the hospital, but also to treatments that are being given that actually are keeping 9 out of every 10 people that would have ended up at the hospital, keeping them at home. And then lastly, there's some great new tools out the CDC has to offer about guidance for us about what do we do in certain situations. And so Brianna made 6 or 7 6 slides, really nice slides about each of these tools in the toolkit. And we're skipping all of them, but they will be in the presentation that we send out. Also, I do want to mention to folks on the line, it looks like everybody has now in the moved from panelists to attendees. If you're logged in as Katie, though, be sure to go in and edit your name. If you're logged in as reporter 1 through 7, please go in and change it so we know your name. It'll make it easier for us to call on you. And I put instructions in the chat on how you can do it. So I look at most of these pieces of information 4 to 5 times a week. Of course, my favorite is the NMDOH epidemiology reports page. Just a wealth, 1,200 data points a week. I think we're providing you about COVID in New Mexico. Christine, Dr. Ross showed you the CDC community levels map. NM Notify. I'm really excited about NM Notify more than ever before. I was out of town here in New Mexico about a week, I guess 3 weeks ago now. And as soon as I got home, I started getting NM Notify notifications. And interestingly, one from a Utah Department of Health and several from DOH. I knew, hey, I needed to test myself, read the instructions, went to the CDC website and did take a test on day 5. I was fine, thank goodness. But I would really encourage the other half of New Mexicans with a smartphone who haven't signed up yet. This is one of the best tools you could possibly have. And if you want, we can talk more about that in the future. Also want to mention the New Mexico treatment site. Brianna, if you can point to that, the findatreatmentnm.com. That's where you go if you need Paxlovid. If you're my patient, you probably are texting me like everybody does, asking me for Paxlovid. But if you can't get a hold of your doctor that way, then please go online, find out where to get treated if you're eligible and get treated. I want to mention there's more information about oral treatment right under that. I've gone over some of that today. And then my favorite lately that I text to everyone who calls me with, I've been exposed to, or I have COVID, or what am I supposed to do? This is the gold standard now. I've probably texted this link to 40 people in the past month. You just go in and put in your circumstances, whether you have COVID or whether you've been exposed, whether you're vaccinated or not. It'll tell you how long to wear a mask, how long to stay home, how long, or whether you even need to stay home. If you're vaccinated and you're only exposed, you don't have to stay home. You can wear an N95 mask to work, but it's really, really helpful. And, I think the first 3 months of the pandemic, I dreamed one day we would have this many tools in our toolkit. And so a lot of times we get questions like, well, how bad will it have to get before we go back to mask mandates? And, I don't think anybody's even talking about that anymore, not even considering it, because we have the tools we need to fight the pandemic. I got 2 more quick things I want to do. So Brianna, next slide. So first, I think you all know, and thanks to your partnership with us, that we took down the 4-week vaccine incidence of cases, hospitalizations, and deaths. And there's a lot of reasons that the data doesn't make sense anymore. For me, the biggest reason is that the people who get PCR tests are probably different than the people who get home tests. They're probably sicker, and because they do PCRs and ERs and in the hospital and the like. But and if you're not very sick, I mean, most of my patients now do home tests, so they're not apples and oranges anymore. I suppose they're still fruit, but they're not really the same. So and there's lots of reasons. So we put a giant disclaimer on the 4-week data. We started publishing this last week and online. And so please, if you're going to use the data, read the disclaimer. But remember, this is not a study of vaccine effectiveness anymore, because there's just so many more variables now. You have people with 1 shot, 2 shots, 3 shots, 4 shots. There are people with 5 shots. And there's so many variables now that the correlations have just gotten weaker. And Christine gave you the data, absolute, very strong protection against hospitalizations and deaths, which is why I'm vaccinated, why I keep getting boosters, is that reduction, not to prevent myself from getting COVID, but prevent myself from ending up in the hospital or being on a ventilator. So it's back up and running. We'll continue to publish it. And we're still hoping to find a national way of counting this data that could work more effectively to express what we actually think is happening. Next slide. Okay, I do want to switch to my Human Services Department. Secretary Hatt, if you live or work in Colfax, Lincoln, San Miguel, Mora, and Valencia counties at the time of the fires in your county, you may be able to get significant extra financial relief for food, and we take fire damages into consideration as well. And so please go to our website. Please look and see if you'll be eligible. It's a 1-week enrollment. All the details are there, but it is only 1 week. And so we want every single person who might be eligible to go. We're also working to open a site in Mora, but we're working on the location in Mora with the absolute best Wi-Fi, which is what we need to pull this off. And so you'll hear more, but we appreciate the great press and help you did getting the word out. And, it's different letters of the alphabet every day, but please keep getting the word out. We appreciate it. Next slide. And then, our community really is safer when we all do our part, using those tools in the toolkits, knowing the levels where you live, and getting vaccinated, tested, treated, getting a well-fitting mask. Jody is telling me I need to wrap it up, but she said we had 30 minutes and we started at 1:10. So I'm still under time, Jody, but I think I'm just going to turn it back to you now and the next slide, and we'll take questions.
All right, thank you, Dr. Grace. We will go to our reporter questions now. And I believe we have a few hands in the chat. So if you'd like to ask a question, please raise your hand and I will unmute you. We're going to start with Julia Goldberg first, and then we'll go to Austin Fisher. Some of the reporters, I may not be able to see your name, so I'm going to ask that when I do unmute you, that you tell us your name and your media outlet. So for now, Julia Goldberg with the Santa Fe Reporter, you're unmuted and you can ask your question. And I do ask that we limit this to one question. We have several hands raised in the chat and we'd like to give everybody an equal opportunity. Go ahead, Julia.
Thank you, Jody. Thank you, Dr. Grace and Dr. Ross, for giving us a chance to ask some questions. I just following up on the wildfire information. I was curious if you had seen an impact on COVID-19 as a result of the wildfires. I noticed that Moore County, the week of May 23rd through May 29th, and the geographic trends had the highest daily case rate, almost twice what it is this week. And I didn't know if that had been a result of evacuations or crews there. I've heard anecdotally that the surge in cases coupled with the smoke in the air had created some complications for people. So I just didn't know if you could speak to the sort of coinciding of those two things. Thanks.
Well, as usual, Julia, you have a really sharp eye. It's a great observation. I think all of those things could be at play. Of course, people with pulmonary disease, smoke makes it really tricky. Second, I think that folks, a lot of people lost their homes, went into congregate sheltering. We had one at Glorietta. Other people just moved in with family members nearby or not so nearby. And so, getting people, increasing the population density like that is going to increase spread if someone has COVID. So I think that's a really sharp observation. I bet if you look at those other northern counties, San Miguel, there's a fair amount of sheltering there as well. So that'd be my take on it, Christine. I don't know if you have any other ideas.
Sorry, trying to get myself off mute. No, thank you. I think you answered that well.
Jody?
All right, next we'll go to Austin Fisher. After Austin, we'll go to Matt Hollingshead. Austin, I'm going to unmute you. You should be able to ask your question now.
Hi, thanks for the time, y'all. This is Austin Fisher with Source New Mexico. So given the spike in cases, which I'm seeing is we're currently at almost 10 times the number of cases that we were at this point last year, will DOH re-implement a mask mandate? Why or why not?
I kind of foreshadowed that question in my closing comments, but a year ago, we had a whole different set of tools and things to fight the pandemic, way less than we do now. We're not having discussions about additional mandates. There still is a mandate in place, hasn't changed for healthcare settings, congregate living settings, just because those folks obviously are more vulnerable. But I think in general, it's just, that's not something that's on the table. We seem to be doing really well. I think when the CDC changed their reporting method that Christine so effectively highlighted for you all today, I think the point of that was, hey, this isn't about infections, it's about serious disease, it's about hospitalizations, it's about deaths. That's what we need to pay attention to. And so despite, you can find any ratio of where we are now to a lot of places in the past where it's twice as high, but our deaths are only a fraction, our hospitalizations are only a fraction. And that's really the sticking point for this state. So at this point, no discussions at all about that.
All right, next we have Matt Hollingshead and then Jared Ebenreck. Matt, you should be able to unmute yourself and ask your question.
Hey, Dr. Grace, Dr. Ross, I got a question for both of you. I guess from the latest, the last month or so, the kind of cases, the tests that have been coming in for positive cases, from what you've collected, how many of those positive results would you say are maybe, I guess, less severe symptoms, the more milder, like strains, like these subvariants? I mean, are you noticing that at all? Those milder cases with less severe symptoms? And also kind of a two-part question, the numbers, I guess, given the amount of home testing there is right now available, I guess, how accurate are the numbers that are coming into DOH?
I think those are two great questions. And I'm going to let me take the second one, and then I'll let Christine comment on that. And then she can also comment on the first one about correlation, because I don't think we're running those symptom correlations because we're not really, contact tracing effort has declined with the advent of all these other tools. But in terms of how accurate, I'm quite confident when I tell you I have no idea. I think we debate this a lot. We're using methods to triangulate hospitalization rates with, BA 2.12.1 or BA2 with hospitalization rates with BA1 or the original Omicron. But you have to assume that there's no difference between the hospitalization, the severity of those two illnesses. And so I think at the modeling team, the number that keeps coming up is 3 times. If you use that method of hospitalizations what that means is for every case we know about, there's 2 others we don't. And then, but there's also some national chatter about could it be 5 to 10? And, I lean a little bit more higher than 3 and less than 10 myself. And then remember that only a fraction of the people who have positive tests at home are even going online to report them. If they had a choice of calling their physician or provider for treatment or going online to have them report their case, I'd rather have them do both. But given the choice, the treatment is the first option. I think it's a really interesting question, though, but it's just one of those with unreported home tests. It's going to be hard to get our arms around. But Christine, what do you think?
Yeah, I think I agree with everything that you just said. And, I just want to make the point that increasing numbers of home-based testing, it's a really good thing. So I think for people to have the ability to get tested and get a diagnosis quickly, that is the number one important thing. Surveillance is going to be secondary at this point in time. So I think there's clearly a large burden of infections, wide-scale infections in our communities right now. I think it's obvious. We all know someone who's infected with COVID-19 right now, maybe more so than other periods of this pandemic. But clearly, we are not seeing that impact on our hospital numbers, and thank goodness we are not seeing that impact on our death surveillance numbers. So I think it is a clearly different pandemic that we're in right now. And I just want to emphasize that, again, the absolute number for case-based surveillance at this juncture, I think that's less important. It's following that trend over time. And we can see that the reported cases to the state still sufficient to provide us with that situational awareness of the trend, what's happening with the trend in cases. But we are shifting our focus much more on medically significant disease or the numbers that end up in the hospital with a severe illness or God forbid, those who end up succumbing to that illness.
Yeah, one last thing too. One thing Christine and I talk about as an early indicator of a new surge is how many people do you know that have COVID right now? Like coworkers, friends, and I throw my patients in there, and like there was a big surge. We've seen a lot. And then what I do, because I'm a total nerd and there's no recovery program for nerds, is I ask them, what kind of test did you get? And so in my not writing down, but in general, what I'm finding is about 4 out of 5 people that I know or patients or others who had a positive test, it's a home test now. So that's where I get that, 4 to 5 times, but I don't think anybody knows quite yet. And Jody, I want to make sure you're aware that we do have some questions in the chat too.
Yes, I was just about to call on Jared Ebenbrecht, and after him, we'll go to Ryan Botel with the Albuquerque Journal. Jared, you should be unmuted and able to ask your question.
All right, just checking. Jared Ebenbrecht from KUNM. Thank you for the time. So I think there's some circles to square here, and I'm trying to understand. We're saying that hospitalizations and deaths are less severe at the moment. the CDC is saying 1 out of 5 infections leads to long COVID. So if we're saying that 3 to 7 times the number of cases that are being reported by PCR on the street, I mean, we're talking about, 2K cases yesterday. And we're talking about a lot of people getting long COVID. So how is the state preparing for that, both the HSD in terms of disability likely claims coming in from long COVID over time as people deal with these outflows of this infection? And given the lack of surveillance, how do you even adequately prepare for the care that's going to be needed for this population? Thank you.
Yeah, that's a really important question. And in fact, I've been in discussions with division chief of in general internal medicine over at UNM, my old job, and the chair of medicine at UNM about long COVID and how we can work more with UNM to have availability for COVID clinics. We're in discussions, not putting pressure on them, I promise. I think we do have a little bit more lead time. Usually the cycle time for a permanent disability or a disability, is a year. And we still don't have an agreed upon definition of what long COVID is, like we have for most other diseases. We're all working. The one I've heard is, you have symptoms for at least 4 to 8 weeks after, and then after that you have, another month. But there's all sorts of numbers all over the board. It's real. I have patients with it. I think that again, that's where we get our sense of urgency when we talk about vaccines, masks, because the best way to avoid long COVID is not getting COVID in the first place. 0% of people who never have COVID have long COVID. 20% who have COVID get long COVID, and so that's the real thrust there. I think in terms of, well, how will we know how many folks are out there? I'm pretty sure. I don't know what Christine thinks about this. I'm pretty sure we're going to start getting some range of multipliers, that we can use that's based on some studies maybe, or other things like that. But it's going to be a big issue. And I think it reminds me of all the conversations we had here and other places last year before, of like, or particularly last year, where people said, I'm just going to take my chances with COVID. And it's like, well, hopefully it'll be a mild illness for you. And then the last thing I was going to say is just, it does seem to be getting milder. I mean, if you look at that first month and the number of deaths in older people, and then you look at the hospitalization rates for Delta and what Christine shared about the hospitalization rates for Omicron, I call it part 1 and 2, but it's really A1 and B1. B1 and B2. I guess it is part 1 and part 2. I think we're evolving toward a milder illness. So if more people are getting COVID and they're not sick and they're not going to the hospital, that's actually a good thing, even if we don't know about it, at least to me. We're nerds and we would love to have every person's data, but we work with what we've got, and we have certainly a lot more data than almost anybody else. Christine, what else?
Well, I want to emphasize that the way that we conduct surveillance may be one matter. Another matter is talking about the importance of avoiding infection if you can. So that hasn't changed. Avoiding infection by this virus, if possible, is highly recommended. And one of the reasons that thank you for noting is because of this phenomenon of long COVID or post-COVID conditions, which does not appear to be insignificant. So absolutely, if it is possible to avoid infection, that is clearly recommended. But what we've found is this variant is highly, highly transmissible. And it has become more difficult to avoid infection, especially now that we are really, as we enter year 3, we're out living our lives, we're moving around, we're traveling, we're gathering. So there's lots of opportunity for exposure to the virus and lots of opportunity to get infected. But I do want to emphasize there is a difference between how can we conduct surveillance from and an emphasis on medically significant illness does not. We do not want to indicate that avoiding infection is not important, because it is. The other thing I want to note is that I believe that there is some data that indicates that if you are unvaccinated, you may have a higher risk of developing a post-COVID condition. I don't think that that's definitive, but I do want to say again, there is that push towards another reason why vaccination is a really important tool.
All right, thank you. We're going to go to someone who wasn't able to unmute their microphone. We have Annalisa with KRQE, and she'd like us to ask her question for her. And the question is, do you have any ballpark estimate on how many at-home tests are being reported to the state?
We
I
do
know we have a
monitor
website
that.
where we could report. Christy, could you answer that one?
Oh, I'm sorry. We do monitor that. I'm sorry, I don't have the number at my fingertips, but I'd be happy to get it and share that with you shortly after the conference.
Okay.
Can I say one other thing though?
Sure.
About that? So this is another one of those very significant shifts from how we used to think about everything when we had no tools. But if that person has a positive home test, and let's say they have a symptom and a risk factor, and they call their nurse practitioner, primary care doctor, whoever it is, and get treatment and don't end up in the hospital, I'm totally okay with not knowing. They go on the quarantine and isolation CDC website, they follow those directions. I'm okay with not knowing. I mean, there will be a time, just like with the common cold and even with influenza, where we evolve and people take care of themselves. If we get down to a hospitalization rate that's as low as influenza, it will become everybody in New Mexico walking around with a tool belt with all the tools, and when they need to use them, they'll take out the screwdriver or the wrench and use it. So I don't think there's any way to get at, non-reported tests.
All right, so next we're going to go to Ryan Botel at the Albuquerque Journal. Ryan, you should be able to unmute yourself and ask your question.
Thanks, Jody, and thanks, Dr. Grace and Dr. Ross, for taking our questions. I wanted to ask you about breakthrough cases that lead to serious illness. So forgetting about the minor cases, but when it comes to vaccinated people who end up in a hospital, what are the underlying conditions and factors that they have? And are those conditions any different than just the risk factors that we've known about for the past 2.5 years, if that makes sense?
Yeah, it's a great question. I don't have data, but I have a lot of word of mouth from talking with the people who run the hospitals on the mat, and likewise. And I think it's I think you're asking a question of what's the correlation between two sort of independent variables, how sick someone is, and then to start with, and what conditions they have. Maybe you said breakthrough cases, so their vaccination status, which I alluded to earlier, is sort of hard to define. I mean, because there's so many different options now. And then ending up in the hospital or even dying. And I don't think there's any question in any of our minds that people with more risk factors are more likely to end up in the hospital than people without. And people who are unvaccinated more likely to end up in the hospital than those who have been vaccinated. And so you can put those other two together. And I think that also lends itself to the reason why our 4-week report has so many caveats to it, is because we're not seeing all those all those home tests that were negative anymore, or the home tests that we're not seeing all of the home tests that are positive, I'm sure, although I have no idea what we're seeing. So it makes it hard, but there's still no question that if you're vaccinated, even fully vaccinated, and one of those people who has a breakthrough infection, your chances of ending up in the hospital or even dying are directly proportional to the magnitude and the number of your risk factors. I think I can say that just as a clinician, and talking to my friends who are hospitalists, that's true. We don't have that data though.
Okay, we have two more hands raised. Dr. Scrace got permission to stay just a little bit longer. We'll take these two questions and we'll have some closing comments and we'll end there. Our first question will be from Algernon Demacia, and we'll close with Stephanie at KOAT. Algernon, you should be able to unmute yourself and ask your question.
Yes, thank you. Thank you, Dr. Ross and Dr. Scrace. Very quickly, 2 months ago when we were speaking about hospitalizations, hospitals were still contending with very high volumes of non-COVID patients still. And I'm wondering if that is still the case, if it's flat, if it's abated, or what the status is of that. Thank you.
It's a great question. And Algernon, you're making the very, very appropriate point that it doesn't matter like who exactly is in the hospital, COVID or not. Once the hospital's full, that next patient, there's no room. And I think we're starting to see a little softening with available beds in the south of the state. In your neck of the woods, a few more over the past week and a half, because I see these reports now, the detailed reports every Thursday, which is tomorrow, a few more open beds in the south. I think our hospitals still, though, in general, are very full, particularly the Albuquerque hospitals, still struggling, but not anywhere close to the levels that they were at, let's say in December of 2020, or even February 2022. So, but going back to second week of the pandemic, New Mexico ranks in the bottom 5 to 10 states for hospital beds per capita, for ICU beds per capita. So we're already starting, I wouldn't say underwater, but we're just above water. And then with the additional COVID cases, it's very, very reassuring to see these low hospitalization rates. Very reassuring, particularly if you do that multiplier in your head. And even the MAT hospital team, we're now meeting every couple of weeks. Everybody feels like they've got this down. They're really clear. The hospital ratings, that self-scoring that we use to determine when we get to crisis standards of care, despite the uptick in hospitalizations, hasn't really gone up very much at all. We're still down in the safety zone on that as well. So generally full, and there's also delayed care. Patients are still a phenomenon as well. People who did want to come in even a year ago, now just getting around to coming back in. I saw somebody on Monday that I hadn't seen in 2 years, and she's older and vulnerable and probably smart. We did a video visit, but it was the first time I'd seen her. She was fine, but I know there's a lot still going on out there. I don't know, anything else, Christine?
You covered it.
All right. Well, our last question will go to Stephanie Muniz at KOAT 7. Stephanie, you should be able to unmute yourself and ask your question.
Thank you, Jody. Thank you guys for having us today. Dr. Scrace, I wanted to know, we talked a lot about the toolbox of the things that we have to prevent COVID, to treat COVID. And I mean, vaccines was a big one for a really long time. With, the potential approval of a fourth COVID vaccine, will the Department of Health be encouraging vaccines even more for people who have not been vaccinated? And do you guys think it'll make a little bit of a difference with our cases?
It's a really, really good question. We had a little debate about this last week or the week before. The vaccines that we're still getting are really ones that were formulated to fight the virus in 2020. And I'm kind of hoping that where we'll be in the not too distant future, not so optimistic about this fall, but next fall, is more of an influenza-like annual vaccine that's more tailored to the most recent variants that have come through. So like if I were a vaccine person, which I don't know, I'm not, I would in a lab, I would be, figuring out how do I come up with a vaccine that works for both Omicron, BA1 and 2 and et cetera, more recent variants. And I think that that with that, like we eventually evolve to with influenza, I think we would see a huge decline in case counts. I think enormous. I might not have mentioned this here, but one thing I've been thinking a lot about lately, and I do not mean this as a negative comment to pharmaceutical companies, but it costs a lot of money to develop a whole new vaccine initially. And if they are going to come up with a new vaccine, if you remember, it took about 9 months till the first folks got a shot in their arm. Whereas meanwhile, COVID is smarter than 9 months and it keeps evolving, every 6 months. And so I get why it would seem really risky for a vaccine manufacturer to jump on every new variant, knowing that the variant might well be gone by the time that vaccine reaches full development. So it's more of I think I'm giving you an answer that's better suited for a health economics class than a press conference. But, I have a pretty deep business background. And so I do wonder sometimes if that's part of the glitch here. And then the influenza vaccine is not a messenger RNA vaccine. And so I'm wondering about that as well. But I would think the best thing that could happen would be that we would evolve to an annual shot. I don't know if they'll ever mix it with influenza or not. I don't know. But, you go in September, October, November, you get your flu vaccine, you get your COVID vaccine. Hopefully by then, COVID would be a little more common in the winter or a lot more common in the winter. It would help too. I know this is like something we think about and talk about. Mike Edwards is really he's our lab director, really done an amazing job and has a lot to say about this. But anything else from those discussions or your own thoughts, Christine, about new vaccines?
No, I would just say, as you stated, we're a long way from where we were when these vaccines were first developed. So I do think we will eventually see a second generation vaccine hit the market. I know there's work on, even an intranasal vaccination as something right at the mucosa that might be more effective at preventing infection. So again, we know that these COVID-19 vaccines are currently offering less protection against actual infection as this variant, the virus has continued to evolve. Luckily, the vaccines remain highly effective at preventing severe illness and death. So would we absolutely encourage folks that haven't been vaccinated yet to get out and get vaccinated. But I would, and obviously what we've already stated multiple times, vaccine effectiveness clearly wanes over time. So the booster is really, really important. And now we're on a second booster for lots of folks. That a second booster is recommended there is a tool on the CDC website where you can click in a little bit of information and it'll tell you whether or not you are due for a booster, and we can share that link as well. But I would not be surprised if sometime in the near future we do see introduction of a second generation vaccines.
And New Mexico will hear from us very shortly after we get the approval for the 6-month to 4-year-old vaccine. I work with a lot of people who are really excited that that's finally coming out. You know, I think Jody's giving me the text to wrap it up. I've really enjoyed the dialogue as always. You guys and you reporters ask fantastic questions, makes me think about things, and you pose a lot of new queries that we haven't had the time to answer. We appreciate your forbearance while we took this very, very much needed break while case counts were low, but they're back up, and we're working on some sort of schedule to ensure you have time to get your questions answered. And we appreciate the pushback too. Really, it makes us think more deeply and more carefully about every issue. And I think that's how it's supposed to work. So I wanted to thank you. And any last words, Christine?
No, I would just say we all need to remain vigilant, be prepared, know what's in the toolbox. Please access the COVID-19 toolbox. We don't know if this is the new normal. I think if we've learned anything, we have learned that this virus can throw us curveballs. So that's why I say we remain vigilant here at the state with close monitoring of cases, hospitalizations, deaths, genetic evolution of the virus, etc. So we will remain vigilant here, and we hope that you continue to remain vigilant at home. Though please note the good news that we did share, that there is clearly a difference that we're seeing now with less severe illness, and it's a very welcome new phase of the pandemic that we're in right now. Over to you, and thank you for having me.
All right, well, just would like to wrap up and thank everybody for listening today. A copy of this will be immediately available streaming on Facebook. We will also post the slides, and I want to thank everybody again for tuning in. Have a great day.
Take care, everyone.